I will introduce our chairperson who managed to come in the crowded traffic of Cairo, Professor Amr Saqr, Professor of Oncology, Cairo University, and he will introduce our distinguished guest speakers. I urge our speakers, please, to keep up with the time, to have some moments for discussion, because we are having some difficult issues that I know will need some discussion. I hope you will have very good, fruitful radiotherapy course during those 2 days, especially today we are speaking about the gynae, then the breast cancer. Tomorrow we will have our first, let us say, industrial-based symposium about radiotherapy, and we will know much hands-on things about the brachytherapy, different techniques. So whoever is here and whoever you can call, tomorrow also is a very interesting day. So I'll move the mic to Professor Amr Saqr and hope for you a very fruitful meeting. Thank you all. Thanks
a lot, Khalid, for your nice presentation. Thanks a lot. It's our pleasure here to become with Dr. Mohammed Sheikh. He's a professor of radiation therapy in Henry Ford Hospital in Blue University. He's speaking today about management of locally advanced cervical carcinoma, and he will illustrate the value of brachytherapy. Shall we give brachytherapy to every patient, or the modern radiation therapy with external beam like IMRT or arc therapy can replace brachytherapy? What is the real value of brachytherapy? Dr. Mohammed.
Thank you. Thanks so much for the invitation to come to two things. When we go to visit centers in the United States and Europe, talk about radiation oncology for cervical cancer, some centers are very, very advanced in radiosurgery and highly conformal radiation treatment or stereotactic body irradiation, and they may think to switch from brachytherapy to SBRT or radiosurgery. Other centers in the developing countries, like in Africa, they do not have the resources to implement a brachytherapy program to treat patients with cervical cancer. So you can argue either way. So what I'm trying to do today is try to go over technique and what has been done and what the difference between SBRT or radiosurgery or IMRT and brachytherapy. What other alternatives people can go to kind of get away from brachytherapy, and why I will not recommend that. So the topic of my lecture is definitive management of locally advanced cervical cancer. Brachytherapy is not an option. So as we all know, cervical cancer is declining in the Western countries due to screening and diagnosis of pre-malignant conditions. So when I started in the United States in '95, I was seeing on an average 3 or 4 patients a week, and now I'm seeing only 1 patient a month. However, it's still a major problem worldwide. In many, many countries, cervical cancer is the most common gynecologic tumor in the female genital system. In 2012, more than 250,000 women died of cervical cancer. So this is a real issue, and we have to kind of put hands in hands to fight this cancer. But whatever it takes, radiation treatment, chemotherapy, molecular target infusions, surgery, you need it. And again, a lot of trends now is going through early detection and also vaccination regarding HPV infection. The staging system, phytostaging system for cervical cancer has been the same for many, many years. Only 2009, they came up with a minor modification. And I split stage 2A into 2A1 and 2A2 based on the size of the tumor, because some prognostic significance basically accumulated, showing that larger tumor results in a worse outcome. But aside from that, the staging system stayed the same without any changes. Cervical cancer management, as we all know, early stages are managed by surgical intervention. That could be radical, modified radical, or simple hysterectomy based on the stage. There is emerging data for fertility preservation for some cervical cancer, they can do trachelectomy or basically observe the patient till labor, and then they can do the radical hysterectomy or modified radical afterwards. Of course, some women may need post-op management if they have adverse prognostic factors in the hysterectomy specimen. And of course, some women may need definitive radiation rather than surgery. And again, historically, we used to teach our residents that patients, women in stage 2B or higher, are managed with radiation treatments and chemotherapy. However, more data are accumulating showing that stage 1B2, the larger tumor, if we go for surgery, we will end up getting radiation and chemotherapy post-op. So the pendulum moved to include also 1D2 as definitive management, as an indication for definitive management for cervical cancer rather than surgical management. Of course, chemotherapy became very important in the management of cervical cancer. Many studies showed that the addition of cisplatin chemotherapy to radiation not only improving local control, but also improves survival. And there was an announcement from NCI, National NCI of America, in 1999 showed that chemotherapy must be combined with radiation in the management of cervical cancer patients. Roughly, it results in 10% survival improvement when combined with radiation, and about 40 to 50% local control improvement when combined with radiation treatments. So it must be used with radiation treatment. So everything I'm going to talk about today, we assume that chemotherapy should be combined with radiation. And again, radiation can be used as definitive management, or can be used as post-op management after hysterectomy, or can be used as palliation. And the dose everyone give is 45 gray to the whole pelvic with concurrent chemotherapy. Sometimes we include para-aortic area, and if they have nodal disease, but I'm not talking about negative radiation, just if we have nodal disease there. And we boost the lymph node with another 15 gray. And we consider intracavitary brachytherapy 40 to 50 gray, 45 gray. So if you combine the dose here, the dose here, we're talking about 84 to 85 to 90 gray total cumulative radiation dose, which results in a very good control of cervical cancer patients. Historically, brachytherapy developed through different techniques across the world. This is historical Manchester technique, Paris and Stockholm technique. And then if the disease is too wide or too large for brachytherapy, intracavitary brachytherapy, we use interstitial implant. Again, with the addition of chemotherapy, the patients who might require interstitial implant for cervical cancer are declining, because with even larger tumor like this, with chemotherapy and 45 gray of radiation, we end up with a very small tumor, or central tumor, that may be amenable to brachytherapy. PET scan. I know PET scan is not available everywhere, but its role becoming very, very important in cervical cancer management, simply because it diagnoses occult metastatic disease in the lymph nodes. Not only the cervix, but in the para-aortic area. And over the last 5 years, we were diagnosing isolated supraclavian lymph nodes in the absence of para-aortic and pelvic lymph nodes. And you may wonder how we take care of this patient with supraclavian lymph nodes with the absence of any adenopathy elsewhere in the body. So it's becoming very, very important, and it's shown, again, confirmed by many studies. So routinely, when we see patients with cervical cancer, we do PET scan, and sometimes we see para-aortic and adenopathy. And the importance is, if you diagnose pelvic adenopathy or para-aortic adenopathy, you have to consider boosting this lymph nodes with further radiation beyond 45 gray. So if the patient is getting 45 gray, you need to boost this lymph node with another maybe 15 gray if the small bowel are enough from the tumor. prescribing the dose to point A, documenting the dose to the point B, and documenting the dose to the bladder point and rectal point. But again, point A is just a point in the space. It does not correlate to the tumor, and does not correlate to the normal tissue. So when we moved from 2D treatment to external beam radiation treatments in the late 80s, brachytherapy also followed this motion, and we moved from 2D planning to 3D planning in the early 1990s. And the results showing that with 3D planning for brachytherapy, the dose constrained to the normal tissue is much better, and the tumor control is higher. This is historical depiction of the point A and point B, and this is an example showing that if you have a smaller tumor, point A might be in fact outside the tumor volume, so basically you're prescribing outside the tumor. While if you have a larger cervix, point A might be inside the tumor, and you have basically this portion without any coverage. So again, point A is no longer this prescription point in modern brachytherapy. Again, when I was a resident, the historical teaching was you have to come up with isosceles curve or panel that follow pear-shaped distribution for cervical cancer. This is not a pear, this is alligator. But again, this is the shape of the field or the isosceles line that surrounds cervical cancer patients. Are we really need to follow this for all patients? The answer is no, because there's some anatomical variations. You end up with a smaller cervix, larger cervix, elongated cervix, short cervix, larger fundus, smaller fundus. So you have to customize your plan based on the anatomical variation for every single patient. You cannot do that if you are prescribing to point A or point B, but you can do a customization if you are prescribed to image-based brachytherapy. And this is what we have been doing for the last 12 years. So if you want to do image-based brachytherapy, I'm going to describe the best case scenario, but you don't have to follow the same exact prescription. You must have a CT scan plan. You must simulate the patient in the treatment position. If you can come up with MRI for the patient at the same treatment position, this should be a plus. But if you cannot get MRI, same position, you can live with CAT scan only. And you have treatment planning system that deliver HDR. And this is what I personally use and like for my brachytherapy treatments, the ring and tandem system. So basically the ring and tandem system consists of the tandem, which is the central portion. As you can see, this marks is 1 centimeter marks. So before deciding what length we would use, we would sound the uterus and see the length of the endometrial cavity. If the patient has a short endometrial cavity, we may use 4 centimeter. Sometimes use only 2 centimeters. So this tandem usually comes in 2, 4, 6 centimeter length. And we have to select the angle of the tandem. So sometimes the uterus is more anteverted or retroverted, and you have to pick the angle that is basically match the patient anatomy. And we have 15, 30, 45, 60 degree angle. Sometimes you insert the tandem first and do the imaging, and you realize that you need more angle anterior or more less angle posterior, and you can decide that based on imaging. Again, if you have 2D imaging of point A and point B, you cannot prescribe the adequate, you cannot prescribe the system that fits the patient's anatomy. And then we have to have the ring, and the angle of the ring should be matching the angle of the tandem. And again, sometimes you use a cap on the ring if the anatomical variation for the women allow us. We must use a cap to reduce vaginal wall toxicities. And again, this must be used also, which is a rectal retractor. So this rectal retractor is basically to displace the rectum more posterior away from the high dose area. This is basically the high dose area here, where the tandem and the ring intersect. So all this area is high dose area. So if you can displace the rectum more inferior, then you end up with less rectal toxicity. We have a different system that we are using now, where you can basically push this rectal retractor more inferior, so you can displace the rectum as dedicated CT scan HDR suite. So the patient will be simulated on this bed, and after simulation, we do the planning and come back and treat the patient in the same exact position. Some centers simulate the patient in one room and move the patient to a different room for treatments, and during this motion, you may end up displacing the system, and you end up changing the anatomy, and this might result in uncertain dose to the cervix and normal tissues. So the best case scenario is if you simulate the patient and treat the patient in the same exact position without moving the patient back and forth. So as I mentioned, we moved from 2G to image-based brachytherapy. So we needed to come up with a language that should be acceptable across the country, not only across the country, across the world. When you are prescribing brachytherapy to point A to point B, people will know I want to report point A dose. But when we moved from 2D to image-based brachytherapy, we needed to come up with a different language, and the American Brachytherapy Society and Jack Estro came up with different definitions. I'm going to go over it quickly to learn that we're using this language in the prescription, in the reporting normal tissues, and also we will compare reports between different institutions to use the same exact language. Simply speaking, again, I'm going to simplify it. This language based on MRI anatomy. So if you cannot have an MRI, you cannot apply this language. It's very difficult to see cervical tumor on a CAT scan. But if you have MRI and you give IV gadolinium contrast, you can certainly see the cervix, you can certainly see the enhancing tumor, you can certainly see the high dose and low dose. So this definition only applies if you have an MRI fusion with a CAT scan. You cannot apply with the CAT scan unless you can see a tumor that's large enough to see. So the definition is GTV, which is basically referring to the cervical tumor on MRI. High risk clinical CTV is basically referring to the entire cervix. Intermediate risk high CTV is adding a margin beyond that, and low risk CTV is referring to the rest of the uterus. Again, you cannot use this one unless you are using MRI fusion with a CAT scan. And this is just a diagram showing that. I'm going to go over it quickly. About organ at risk. Again, for cervical cancer, we care more about rectum, bladder, sigmoid colon, small intestine. Again, in the old days when we were using point A and point B, you had no clue where the cervix, where is the sigmoid colon, where is the small bowel. But nowadays, with the CAT scan and MRI, you can see the bladder, you can see the rectum, sigmoid colon, and small intestine, and you can come up with a DVH describing the dose of the structures. So, similar to external beam, DVHs is giving us the volume of tissues and the dose required. And as of now, we use the V100 for the volume that gets 100% of the dose, and V90, V95 to document the dose to the cervical tumor. And for normal tissue structures, we use the maximum dose 2 cc of the tumor, 2 cubic centimeter. So all these stories resulted in a very, very good success story for brachytherapy for cervical cancer, where the 5-year local control is almost about 90%. So you have a tumor that can be cured in 90% of the time using external beam radiation treatment, chemotherapy, and brachytherapy. And when we are shifting towards image-based brachytherapy, the results are even better. Actually, this year ASTRO, when I reviewed the ASTRO abstract, we have results from Europe showing that the results could be 95% cure for stage 2B and above cervical cancer when you are using image-based brachytherapy. So it's a working treatment, an effective treatment, but the main challenge is distant failure. We end up curing the patient locally, and the tumor is sterilized in the pelvic, but we end up with lung metastasis or bone metastasis, liver metastasis that's more for more aggressive systemic therapy. This is just one abstract published this year showing that with image-based brachytherapy, show that we can cure the majority of cervical cancer patients. So why omitting brachytherapy? If you have a treatment that's working, a treatment that's highly effective, a treatment that is done as an outpatient without patient's admission, why need to get away from it? So, two reasons. One reason is, as I mentioned earlier, for countries or centers where we have no resources to invest in HDR brachytherapy. It is understandable. On the other hand, for highly developed radiation oncology centers where they use SBRT and radiosurgery, they are looking into replacing brachytherapy with these. I'm going to go over some results with you. But this is a reason for switching from brachytherapy to something else. So again, the first study trying to get away from brachytherapy was published in late 1990 and looking at preoperative chemotherapy before hysterectomy. Downsize the tumor from 2B and above to less than 2B, so the surgeon can go in and perform radical hysterectomy. So again, there's many smaller retrospective studies published, and when meta-analysis was done, looking into outcome before chemotherapy, before hysterectomy, or hysterectomy by itself, the conclusion was the author that the chemotherapy preoperatively remained unclear whether it will help before surgery or not. So as of now, it is not a standard of care to do preoperative chemotherapy to reduce the size of the tumor so you can do radical hysterectomy. This is one of the studies that is everyone quoting that it's a good study to use chemotherapy for hysterectomy, so you don't have to use radiation, you don't have to use brachytherapy. And the study design, we have a lot of issues about it, but simply, patient were randomized into neoadjuvant chemotherapy with 5-FU and cisplatin, followed by radical hysterectomy, and the other group were randomized to radiation alone and brachytherapy. And again, the studies have a lot of issues and flaws, but I want to just highlight that the poor outcome in post-op was talking about 40-50%. Initially, we were talking about 90%. You can tell the difference. Also, the study did not use chemotherapy. As I mentioned, it's a standard of care. You use chemotherapy with radiation. And 1/3 of the patients randomized to surgery ended up getting radiation treatment as well. So it is not a clean study from this respect. So this is one example of the underdeveloped countries using pre-op chemotherapy to reduce the size of the tumor so they can do hysterectomy, radical hysterectomy, in lieu of radiation treatment. How about if you have the technology, you have the brachytherapy, you have the IMRT, you have this radiosurgery? Can you do that? Brachytherapy in general is more involving. It requires you to be available for almost 4 or 5 hours to do a procedure. Radiosurgery, you can spend maybe an hour of your time doing planning, contouring, and actual treatment. So it makes sense for me to invest my time in radiosurgery rather than doing brachytherapy. But for the resident in the room, I want to highlight 2 important issues. Internal organ motion. When we do radiation externally, we have to come up with a plan that includes a margin around the tumor to account for daily setup, radiation, and internal organ motion. Cervical cancer is moving a lot. We had a study 4 or 5 years ago that showed the superior inferior motion of the cervix is more than 2 centimeters. What I mean by that is if you have superior inferior organ motion more than 2 centimeters, your margin must be at least 3 centimeters. If you have 3 centimeter margin to account for the organ motion, then you will definitely end up with a lot of bladder dose, a lot of rectal dose, a lot of small bowel sigmoid dose. So what you are trying to mimic is come up with a plan from day 1 for 5-6 treatments and not doing the images every time. You are definitely missing the internal organ motion, and you are definitely increasing toxicity to a normal tissue. How about internal shrinkage of the tumor? When you have a cervical tumor and this tumor shrinks, with brachytherapy, we repeat the images each time, and each time we plan based on the cervix as of today. prescribe 40 to 45 gray for cervical cancer using brachytherapy. And some people say, well, we can easily prescribe that using radiosurgery. But let me show you something. This is a radiosurgery image. I hope you can see this isos line. So this basically, the red line is our 5.5 gray for cervical cancer management. But if you look at the internal isos lines, this green line and this color, it is 8.25 and almost 11 gray. So what is actually taking care of the cervical cancer patients is not this line or these two lines. This is exactly the opposite for radiosurgery, and the opposite for IMRT, and the opposite for SPRT, where the isos line, as we get in, it is basically lower. So with cervical cancer brachytherapy, the isos line is definitely higher, closer to the tumor, and lower away from the tumor. So the dose of brachytherapy is not the 40 gray or 45 gray. It's definitely double or triple this dose. The organ motion is addressed adequately with brachytherapy because the system moves up and down with the motion, while the external beam, the cervix, basically move in one direction, and the brachytherapy or the external beam is fixed. So we're definitely missing some tumor. And again, I just went through some studies published. I can count only 3 or 4 studies looking at radiosurgery for boosting the cervix rather than brachytherapy. Again, we're talking about 10 patients, 5 patients, 6 patients, and every paper showing that the brachytherapy can be easily replaced with radiosurgery or SPRT. But again, all these papers are not accounting for internal organ motion, are not accounting for high dose internally for the isos line. It's just examples. And in conclusion, women with locally advanced cervical carcinoma can be potentially cured with a combination of external beam, chemotherapy, and brachytherapy. Where radiation treatment planning and delivery significantly improved in the last decades, its conformity is not even